Can you guys hear me today?
I can. Can you hear me?
So great.
Yes.
So now the counseling class that was with different folks. I mean, like I took a counseling elective. I did. Well, that was a mental health last semester down there. So this must have been not with Mike, or this was with someone else.
Yeah, it was part of a master's program.
Okay.
But it was Jack Sutton was one of the teachers, and actually I can't think of the other teachers they had.
They might not be there. I'm trying to just obviously I'm trying to work out who's there now. So probably wouldn't be anybody left like right because Karen wasn't there. Yeah. Okay.
Jack Sutton is now retired. Actually, just the gentleman's face, I can't think of his name.
You're on high side?
Yeah, so it's just, so I just started looking, I think I had to take 3 or 4 or 5 counseling classes as a concentration. I think when you take the class that I took with them.
I've forgotten the ones I took last year, and
But the adult learner, and then there was action research.
Right.
I think I enjoyed being in a setting where you were just completely focused on
Last fall? Oh, this past spring. Right, that would have been nice to know. Right. Did it cycle? It's a full load. Almost sounded like that. That's why I asked you about the butterfly. But a gauge is a gauge.
Okay, now I'm not hearing you. Hello, ladies. Hello, ladies. Hello. Oh, did I forget Jackie? Where's Jackie coming from?
Yeah, because it's gonna run on high fire. Right. I ain't gonna spend no money on that. I don't need high fire. So what are you doing now?
Okay. So let's just wait for Scarborough and Jackie. One. How did everyone do with the homework?
Good.
Excellent. We will go over answers tonight. Actually, I told you to do the stuff online, right? Remind me, refresh my memory, please.
Yes.
Yeah, you had us do the stuff online because quite a few of us didn't have the actual study. Was it a study guide or a study? I don't have it.
Yes.
There we go.
Yeah, I don't have it either.
See if there's a voice on this.
Hi, Scarborough. Hi, Ange.
I assume there's a voice on this. All right, I think we're up and running. The voice part isn't you, correct? Yeah, you
Hi, Ange. Hi, Terry.
Hello?
Yes.
No, I'm not hearing anybody there. I see them visually. I don't hear anybody. I'm just using the laptop here. I wonder if I run it through the ceiling projector, if that would be different.
Test, test, test.
I mean, our other laptop, it comes through our laptop fine, so.
Yeah, when Ange was on the first time, it worked just fine.
Let me just see if I see anything on this. That should be fine.
Test, test, test. Test, test, test.
I could try putting it on a projector and see if the audio comes through that. I don't, yeah. Okay, I'm just gonna, can you stay on with me for a second?
Okay, so then I emailed Amy last week, and all of you that don't have a study guide will be getting a study guide. So if you just keep track of the work to be done each week, you know, when you get it, it's not like you're going to be getting behind because you're already reading and you're doing the stuff on evolve. The stuff in the study guides is going to be practiced, and it's going to be good for you to practice. So tonight was all about tonight is all going to be about chapter 5 and chapter 6 in your Kins book.
Mm-hmm.
Let's just give Scarborough a chance to get connected.
Let me just try something really quick.
I can hear you fine, Terry.
Okay. So, can you hear them okay?
Hi.
Hi, Ange.
Hi, Doreen.
Welcome.
Okay. Thanks. Thank you. We're all set. It actually ran through the Thank you.
Oh yeah, they can see me there. They can see
I
me
can
there.
see you.
Okay.
I can't see you on the big projector, but I can see you on the laptop.
Okay.
I just have to run down.
Turn on. That's good. Yeah. Thank you.
Okay.
Top of the fucking ladder.
Give me 1 second.
Slide sideways. 6 a.m. Yeah. Yeah. When I seen him out in the dooryard, I see they were cleaning that trailer on it. That's why I mentioned Ricky yesterday.
Doesn't matter with me.
Hi, this is Scarborough. Could somebody just say something? I want to check our audio.
Hi.
Hello. Oh, thank you.
Test.
I think they can hear us.
Yes, I can hear you just fine.
Yeah. Yeah, it's thanks.
Okay. So we're waiting for Jackie. I'm going back and forth with Network Maine through email to see that Jackie gets connected. So for last week, you just had some stuff on Evolve to do for chapters 3 and chapter 4. And then you were to read chapters 5 and 6. And we were going to hold off on anything in the study guide because this is the study guide, and the only one I believe that has this book is Diane.
Yep.
So the rest of you that don't have it, Amy or Jamie, whichever one, I emailed them last week, and those were ordered for all of you. So when you get them in the mail, just let me know you have them. And as I said, don't feel like when you do the study guide, you're going to be behind. I'm more concerned that you do the stuff on Evolve. So do the chapter quizzes for practice. Do any of the stuff that we talked about in last week's lecture. Okay? And then when it comes time, do the exam on Evolve, and the exam grade is what I want you to put on your checkoff sheet. Okay? Make sure you do that and put it in pencil, because if you want me to look at it, obviously you want me to give you the final grade, and then you put the final grade in pen. All right?
Yeah.
So let's just start on chapter 5, page 58 in your textbook. Okay, so the scenario for tonight. All right. Before I forget, let's go ahead and just take attendance of who's here. I have Liz, right? Okay. I have Ange in Scarborough. I have Diane and Brittany. Right. Okay. Okay. And there's no one hiding in the dark that I can't see. Okay. All right. So we have lost Micheline, and Jackie hasn't been able to join us yet. So. All right. So Liz, would you go ahead and read me the scenario to start chapter 5, please?
Many types of patients seek medical attention and care in the physician's office. Each has different needs and different concerns. Even if the diagnoses are similar, communication and interpersonal skills are vital in meeting these needs and providing optimum care to the patient. However, the patient is not the only individual to consider. Family members often are crucial to the health and well-being of the patient. Lucille Cloyd is an 83-year-old patient who has been diagnosed with pancreatic cancer and is seeing Dr. Neal for treatment. Her daughter, Sarah Smithson, helps to care for her. She is close to her mother emotionally. Sarah also is Dr. Neal's patient. Although Sarah does not want to see her mother in pain, she suffers with the knowledge that life will be very different without her. Mrs. Cloyd is widowed and visits the physician once a month in addition to receiving hospice services. She is a good-humored woman who feels that she has led a fruitful life, yet she has moments of depression. She has been living with Sarah and her family for 2 months and enjoys interacting with her 2 grandchildren and the family's pets. The medical assistant must consider not only Mrs. Cloyd, but also her extended family. Compassion and sensitivity are necessary to care for this patient, in addition to excellent listening skills. A good knowledge of human relations helps the medical assistant make Mrs. Cloyd's medical care as pleasant as possible under the circumstances.
Yes, very good. Okay, so we talked about vocabulary. It's important that everyone read over the vocabulary. Again, you don't have to memorize it, but it's going to be good because when we go over it in class, I want you to have knowledge of it. So what's the old adage about first impressions on page 59? Diane?
First impressions usually last forever.
Right.
If you make a bad impression, that's what they're going to remember.
Right. So if I come into your office or you meet me for the first time and I have my hairs in curlers and I'm wearing my pajamas, what are you going to think?
She was too lazy to get dressed today.
Yep. Okay, and then someone who takes the time to, do the hair, at least be presentable. They don't have to do their nails or makeup because some people just don't like to wear makeup. And then, they look put together, so to speak. Okay. What would you think of that person, Brittany?
I would think that they actually took the time to, get ready and that they were excited to meet me.
Excellent. So truly, how you, look and act within the practice, really you are setting the tone for the office. So some offices you will find actually have a dress code. Some offices might have scrubs. You might wear a scrub top and a scrub bottom. Or, as I mentioned last week, I will wear black slacks and a scrub top or dress slacks and a dress top. It just depends on what practice I'm in and what I'm doing. This week I'm filling in for an office, so I am able to wear scrub tops with my black slacks when I'm taking care of patients, doing ultrasounds and physical modalities. And then if I'm covering the front desk or doing the billing office, I might decide to wear my black slacks and a nice dress top, just a button-down dress top, something simple yet, is nicer than usual t-shirt and a sweater or something like that. So your interpersonal skills, your verbal communication, as well as your body language sets a tone in the practice. So you want to make sure, as we have mentioned, that your personal stuff stays outside the office. It doesn't get brought into the practice. All right, so then what we're going to discuss in this chapter will be first impressions, your verbal and nonverbal communications, spatial separation, value of touch while communicating, some elements of transactional communication, barriers to effective communication, and certain defense mechanisms, and listening and dealing with conflict. So some of the questions that I want you to consider while we are doing this is, how can you treat patients as individuals during a busy day? Because we all know that we can get very busy. We can be answering the phone. We can be checking patients in. We can be checking patients out. The doctor might need something. Our coworker might need something. So think about, how do you treat patients if you have a very busy work day? And then also, another thing I would like you to think about is, how do you as a medical assistant communicate effectively with a patient's family member? And then, how do you develop good listening skills? How does doing that make you a more effective assistant? And then also consider, how do friends and family members play a role in the health of the patient? So the patient's perception of the physician's office and the other staff members is really important. It might not be accurate at all times, but what the patient perceives is just as important as what is actually happening. So the example that I gave you earlier about, meeting you in my hair and rollers and my pajamas on, I might be very lazy that day, but believe it or not, turn around the next day and I can be very well put together and very professional. It just means that I didn't feel like it that day, or you caught me off guard, or, something like that. Most people obviously have fair warning and you have time to prepare, but always remember that perceptions don't always take things at face value right off, because that first impression you get from someone in an office, they might be having a really bad day, and you can't take that as the standard for that office or for that person. Now, if it constantly happens every time you go in that office, then you might want to say something to someone else, like, is that person having a bad day, or is there something wrong? Because the last 3 times I've been in, they've been really, harsh or curt to me. And you can feel free to be able to say that to someone, because they might not be aware of it, that staff member might not be aware of it, and if that's the case, then it would be helpful to bring it to their attention, because if they're not aware of it, they need to be made aware of it. So first impression, you want to make sure that people really are you know, giving themselves, putting themselves the best foot forward first, or put your best first as much as possible. As I mentioned, just keep the personal stuff, like I said, put that red dot or thing on the door as you walk in and tap it, and that's it. You leave the personal stuff behind. So you try to create a good impression within the practice. Okay, so not a lot of places will come up and shake your hand, especially in healthcare. With all of the germs and everything going around, I think you find in healthcare people are more hesitant to just put their hand out there and say, hello, welcome. They might, give you a nice big smile and welcome you, but you're going to find that less and less will they shake your hand, okay, just because of the field. So physical appearance is important. Usually we form our opinions in the first few moments. So that includes the attitude, if the person is compassionate, and do they smile? So if someone walks in and they just greet you and say, hi, how are you today? And they don't smile, that's like, I wonder what's wrong with her. Or, hi, Liz, welcome to our office. What can I do for you today? Great to have you here. Doesn't that sound much better? Feel better? Okay? Kind of puts you at ease as soon as you walk through the door, because the last thing we want to do as a patient is go into a doctor's office. So it's important for us to be as welcoming as possible. All right, so I already touched upon introductions. Just introduce yourself, smile, wear a name badge. Okay, so you guys will get a kick out of this. So the office that I'm filling in at, I have a name badge, and it's a magnetic one, so I don't take it home every night. I leave it on the file cabinet because it's metal. So I just stick it on the file cabinet. So the last few times that I've been in that office, I have to go hunting for my name badge. Someone takes it and moves it around on me. So I finally found it yesterday, but in the meantime, about 3/4 of the day, I had this green sticky note on my shirt that I wrote my name on it. So patients would know who I was. And they actually thought that was quite original. So it got them to laugh, and it kind of broke the ice because some of the patients I didn't know and some I did. And so whatever you can do to help break that ice and make patients feel more comfortable definitely helps as well. Okay, show the patients around the office. If this is their first time, give them like the little mini tour. Introduce them to other staff members who might be present, and just to help make them feel at ease. So remembering that our verbal communication as well as our nonverbal communication is important. So let's turn to page 63 and the critical thinking application. How might touch be an important communication tool with Mrs. Coyd? What do you think, Diane?
I think I think that she'll feel more important, that you care about her if you have more contact with her.
Yes. All right. All right. Another form of communication in the office is the medical record. And it must be legible. Your spelling and grammar must be well used. If it isn't in the medical record legally, it didn't happen. So if If it wasn't in the record, it didn't happen. Okay? All right, and anything that might influence the patient's mental, physical, or even spiritual health can be added to the medical record because all of that affects the whole person. When we do speak to the patient, this is all about verbal communication. So we can go back to page 60 if you want, 60 and 61. When we speak to patients, we want to speak clearly and we want to enunciate properly. We want to make sure that we vary the pitch of our voice. We want to use appropriate volume. So someone who is on screech all the time, we might not want them to be at the front desk. You want to speak at an audible level and make eye contact. So you can speak in an animated fashion, but not like this all the time. You know, you're using your hands and arms and moving your body, and don't speak animatedly all the time. You can show concern and try not to interrupt the person who is speaking. The tone of your voice is very important in communication. Never be sarcastic. Try not to be rude. Never make an inappropriate remark and follow it by saying, "I was just kidding." And take care not to hurt anyone's feelings with words or phrases. Your verbal communication depends on words and sounds. All right? So you all know as well as I do when we get harried and flustered and we have 10 different people coming at us at once, it might be really easy to answer curtly. So you want to just take a step back, take a breath, collect your thoughts for, 30 seconds, do it, and then come back to it. And if you catch yourself doing it in front of a patient or a coworker, just, say you're sorry, excuse yourself, and gather yourself back, and then go back to doing what you're doing.
Yeah.
Okay? Patients who need tender care.
I can hear it clearly.
I know. It wasn't, for some reason, it wasn't working out earlier, so we tried that as a way for you to get some kind of audio. I don't know why it's not working on here.
So just remember that patients in the office need to be cared for. They have a lot of great concerns. They might be apprehensive, and they might even be fearful.
Because the voice is coming from there, so it's just.
I understand that, and I love to move you.
I can. Do you have a headphone? Then I can.
I think it's my school.
Are you having trouble, Ange?
I cannot hear them already.
You're having trouble, Ange?
I cannot hear them.
Okay.
They can hear me, right?
I can hear you.
They're not sure.
I can hear you.
I wonder if you can hear it clear, maybe not. Maybe it's just the same.
The last time was fine, right?
Yeah, I know.
Okay, just give me a minute, lady. Okay.
Yeah,
A lot of reverb.
it's
Okay.
the voice you it's so awful.
Have to turn it down. It's because she has the two speakers turned on. So when we listen to patients, we need to allow them to do most of the talking. We don't want to offer a lot of personal information about our own life and problems. We want to share only positive experiences and only briefly. Do not burden the patient with our problems at any time. Nonverbal communication can be messages that are usually conveyed without the use of words. This is where I mentioned earlier about body language, gestures, mannerisms, and hand movements. Your body language can be partly instinctive, partly taught, and partly imitative. So critical thinking application 5-2 on page 64. How can the medical assistant be sure that Mrs. Cloyd understands how she is to take her medication? What do you think, Liz?
She can ask her, or when she says it, make sure that she gives feedback or says that she understands it, or make sure she's conveying the message so that both her and the daughter can hear it, be clear and concise. And...
Right. So often that we'll find older patients that do not appreciate their instructions being given to their caregiver instead of directly to them. So how can we as the medical assistant place the primary focus on communicating with Mrs. Cloyd, yet at the same time make sure Sarah understands the instructions and care? Brittany, we're on page 64, critical thinking application. How do you think you would answer that one?
I would direct it towards the mother, and I would ask the daughter if she understands or if either one of them have questions, kind of make it involve both of them.
Perfect. Excellent. So remember too that our body language involves eye contact, facial expression, hand gestures, grooming, dress, space, tone of voice, posture, and touch. Remember that your appearance is vital to your nonverbal communication, and it can also present conflicting nonverbal information. So just be aware of your appearance and how it may affect different people. So a successful medical assistant will express self-esteem, confidence, pleasant facial expressions, and caring attitudes. If we have a conservative appearance, what does that say about people, Diane?
I think that makes them look professional if they're conservatively dressed, or looks
Right,
more
and
professional.
It does, and it helps to avoid any type of blocking communications because then the patient sees them as someone in authority or someone who knows about something that can help them. When we talk about proxemics, this is the study of nature, degree, and effect of the spatial separation of individuals to naturally maintain and show separation relates to cultural and environmental factors on page 62 in your book, Proxemics. It's the need for boundaries or personal space, and it's demonstrated by how patients in the reception area choose to sit. So you ever walk in and you see that there's this big waiting room and everyone is spread out all over the place. That's space. Everyone needs their own space. Same thing when we are in the treatment room with the patient. They need their space too.
At 10 years old.
So, spatial boundaries. Public space is usually 12 to 25 feet. Social space is usually 4 to 12 feet. Personal space is 1.5 to 4 feet. And intimate space is touching to 1.5 feet. So what can a touch mean? A touch in the medical profession can be comforting, or it can promote sexual harassment lawsuit. So you just want to be very careful about that, and we'll get into some examples. You want to avoid claims of battery, so be very careful when you're touching a patient. Non-consensual touching can be considered battery in today's litigious society. So Brittany, can you share any experiences where this might be an issue for taking care of patients?
It definitely, you want to kind of feel the situation and make sure that the touch is welcomed. You definitely don't want to kind of have a confrontation and then go and try to touch somebody because it might not be welcomed. I definitely kind of feel the situation out before doing it.
Very good. It really comes down to appropriate manner. What do we consider the appropriate manner? So pay attention to posture and positioning. Because posture and positioning with a patient can indicate depression, anger, excitement, fear, and sometimes an appeal for help. So when we talk about the process of communication,
There we go.
hi there.
You hear her. Hi.
Hello.
Hi, Doreen. We're just trying to, we're needing help.
Okay.
There we go.
Yep. Thank you.
Oh, good job again.
I didn't do nothing.
Thank you.
That's just the calling thing. Okay. We'll leave this here for the back.
Sorry. That's okay. Thank you. I thought you were going to be at home tonight.
I can't. I tried to do it last night after I left class. My computer doesn't want to update the newest drive. I was just telling this lady here that I have another computer, but it's going to have the camera on top of the camera on the computer, so I'm going to try to set that one up. If it don't work, then I have to stay here.
Okay.
Thank you, young lady. Have a good night. I know.
page 63 in your textbook. When we talk about channels, over on the right-hand paragraph, channels can usually be a spoken word, a written message, or your body language. Encoding is when the sender encodes a message, which usually means that they need to specify a method of expression using words in other channels. Using words in other channels.
Been around a long time.
All right. We want to make sure to communicate well. We must have a general understanding of the process of communication. Usually when two people interact, they both function as senders and receivers. When we decode messages, it means that the receiver decodes the message according to his or her understanding of what is being communicated. Noise contributes to the misunderstanding of messages. So noise is anything that interferes with the message being sent. It can be internal, physiologic. We usually look for feedback, whether it's a verbal expression, body language, or a nod of understanding. If you look over on page 64, you'll notice the transactional communication method. This is where the communicator sends and receives, responds, decodes, feedback, messages, and so on. Listening, it's when we pay attention to the sound or hearing something with thoughtful attention. Listening is important for us as a medical assistant to develop. What do you think usually prevents you from listening? What do you think, Jackie? What prevents us from listening?
Not paying attention, not listening to you talk, kind of daydreaming.
Yes, our own thoughts distract us from listening. Situations in our lives might make it hard for us to listen. Conversations might seem meaningless and unimportant, or we might have too many messages that come to us at once. Emotions such as anger might render us unable to listen. Exhaustion makes listening difficult too. I think F6 mutes speakers. If there's a way to mute your speakers.
I have a little button on mine.
Okay. There should be some way to mute. Thank you. Very good. Okay. Listening to patients. Patients must know that we're listening to them, not only hearing the words that are being spoken, but attempting to interpret what the patient is trying to communicate to us. Paraphrasing. Over on page 64 in the left-hand column, paraphrasing. Paraphrasing is listening to what the sender is communicating, analyzing their words, restating back to them that we have received and confirmed their message. We want to clarify their thoughts and then help to indicate that there's a common understanding. So they give you an example of paraphrasing on page 64. That's a pretty good paraphrasing. Whenever someone says something to you, you want to say, repeat it back to them so that you're both on the same page. You want to make sure that you are asking open-ended questions. Can you explain what the pain feels like? Well, it's dull, achy, throbbing. When did you first notice these symptoms? Oh, about a week ago when I was raking the lawn. What are you usually doing when you have the symptoms? Usually it's movement or sitting for too long. And what do you think is causing the symptoms? I'm not sure, but I noticed when I was raking a week ago, I felt a pop in my back when I bent over to pick up the pile of leaves. You want to observe carefully, so watch for signals from the patients, such as tears, sad expressions, or a volatile temper. Defense mechanisms over on page 66. Verbal aggression. Verbal aggression is what, Liz?
Verbal aggression is something you say to attack someone else, to where you disregard the original complaint, but you just go after something else.
Okay, what is sarcasm, Brittany?
I'm gonna read it.
That's fine.
All right. The word sarcasm comes from the Greek word sarkasmos, which means to tear flesh or to bite the lips in rage. This is quite an accurate definition of the nature of sarcasm. It is biting edge added to words that a person states with the intent to cause pain or anger. Sarcasm is hostile and cruel in most cases, and some individuals use it constantly, thinking it is quite witty. On the contrary, it often makes bitter enemies of its victims. For example, of course, it's a nice dress if you like tents.
Don't you just love it when people do that? So what do you think would be the best way to handle sarcasm, Jackie?
I've been trying to get better at that at my work, and I usually just say, I'm sorry. If you could just hold on a minute, I'm trying to understand what you're trying to say to me. So they kind of have to think of how they're saying it to you, and then maybe change the way they're going to say it. Because I think sometimes if people just say it, but if you say something like that, then they think about it the second time around because they're wondering, did you get it? Or did I say something wrong? Or something like that.
And you could ask them to repeat that and say, did you mean what you just said? What do you think about rationalization? What is rationalization? Diane?
I think she's answering, but she didn't take her speakers off mute.
Yeah, she's still on mute.
I did. I totally forgot about that. I think it's when they try to explain something that's wrong, even though they know it's wrong, they try to make it right. They try to tell you that it was, that it wasn't their fault, that they, someone else should have done it or didn't do it or.
Yeah. Okay. What about compensation? And when a person compensates, what does that mean?
Compensation is a psychological mechanism through which feelings of inferiority, frustration, or failure in one area are counterbalanced by achievement in another.
Okay. That's fine. So the best way to handle compensation instead of you want to ask questions. You don't want to be judgmental. Okay, so maybe ask the person, how long did they exercise, or what was your diet like last week? We don't want to make judgment. Okay. Regression. Regression is the reversion to an earlier mental or behavioral level. And how would we handle regression? We want to precede our response with a positive statement that may make the person who's exhibiting that regression feel more uncomfortable admitting inappropriate behavior. So that's a good try. Repression is a process whereby unwanted desires or impulses are excluded from consciousness and left to operate in the unconscious. So a person who is repressing his or her feelings, you might want to say, I understand that you're in this difficult situation. If you want to talk about it, I will be here to listen. Apathy is a lack of feeling or emotion, interest, or concern. So the best way to handle that might be to attempt to get past the pretense. So, I know you really do care about your grades, and of course you can pass the class. How can I help you study and prepare? If someone is feeling displaced or displacement, this is a redirection of an emotion or an impulse from its original object, such as an idea or a person. How do you think you would handle displacement, Jackie?
Well, sir, Jeremy, I'd like to just, repeat what I was explaining to you earlier. Take your medicine every day, try to exercise, just go over again what you tried to tell him the first time, and hopefully he'll listen the second time, even though you didn't do it the first.
Right.
Because he's not focusing on everything else, but now he's focusing on what you're saying.
So what is denial? Brittany?
Denial is when you don't want to accept reality or what's really happening, I guess is how I would explain it.
That's good. And how would you handle denial, Liz?
You want to make sure you listen to them and express empathy and avoid saying things like, I know how you feel. And
good. Okay, physical avoidance. And what is physical avoidance?
About anything that serves as a reminder of event that induces the negative feelings.
Mm-hmm. And how would you deal with physical avoidance, Diane?
Try to get them to go. If they won't do or go somewhere that has bad memories, try to get them to go someplace else and make new memories or have good memories.
Good. Okay. Conflict. When we deal with conflict in itself is a struggle. It usually results from incompatible or opposing needs, drives, wishes, or any external or internal demands. So critical thinking 5-4. Why might Mrs. Cloyd and Sarah experience conflict at this stage in their lives? What do you think, Jackie?
I think sometimes, depending on age difference, sometimes that matters. For me, I've noticed that younger people think they know it all, where older people have done it, so they do know it, but they can't tell that to the younger people.
Right. But then we also have the older people who think they know it all.
Correct.
And what happens is we just don't understand each other's situation. So So conflict can actually be beneficial to relationships. It can be constructive. It can help people to learn about each other. It can promote a stronger understanding as well as deeper levels of intimacy. So conflict actually can be a good thing. Assertion over on page, I think it's 69, right? Assertion. Yes, assertion is on page 68, and it is in the column underneath conflict. So assertion is when we state or declare positively, often usually forcefully or aggressively. Non-assertion is usually the inability to express needs and thoughts or the refusal to express them. When we are resolving conflict over on page 69, every relationship experiences conflict. The first impulse usually is the fight or flight syndrome, where we want to put aside our thoughts of personal attack and try to think logically first, but that doesn't always happen. So some of the tips for resolving conflict. First, try to expect conflict. You do not want to fear it or dread it. Realize that conflict can be healthy. So it lists right here underneath resolving conflict in the column, it gives you the tips, okay? Accept that others have legitimate, viable opinions. I'm not going to go into each one of those. You have them right there in your book that you can read them. Boundaries. Let's talk about boundaries. Boundaries indicate limit or fixed extent. So setting boundaries usually at work helps to avoid some of those awkward situations or misunderstandings. Over on page 69, there's 5 tips there, 5 steps in setting boundaries at work. If you haven't read them, read them. It would be good to utilize them. That might be helpful for you, Jackie.
Yeah.
So some examples of workplace boundaries, calling the person by their first name or Mr., Miss, or Ms. or Mr. Refuse to listen to offensive jokes. Refrain from forwarding emails that are not business related. Leaving the office door open when speaking with someone of the opposite sex. Dating people who work for the same facility or patients from the practice. Those are no-nos. So it goes over those steps. When to say, what to say to stop inappropriateness. Just simply say stop. I am not interested in hearing this topic, or I am not interested in seeing this behavior. Self-boundaries, these are pretty much your own rules about how you will behave in the workplace and what you will and will not accept or condone. Crazy makers. Now, over on page 70, we go through the different types of people. So in a book, Looking Out, Looking In, Interpersonal Communication, Ronald Adler and Neil Town discuss the concept of crazy makers, which is credited to psychologist George Bach. And George Bach, he developed the theory of creative aggression. He nicknamed this passive-aggressive behavior crazy making. According to Bach, 2 types of aggression exist: clean fighting and dirty fighting. Crazy making was his name for dirty fighting, which is detrimental behavior for all involved. The term partner is used loosely to indicate the opposite side or victim of the crazy maker. Bach described the characteristic types of passive-aggressive individuals. So, we're going to go through each one of these. The first one is the avoider. What does the avoider do, Brittany?
The avoider refuses to fight. When a conflict arises, they leave, fall asleep, pretend to be busy, or keep from facing the problem in some other way. This behavior makes it difficult for the partner to express feelings of anger and hurt because avoiders will not fight back.
So can you think of someone in your life who's the avoider?
Yeah.
Okay. The pseudo accommodator, Liz.
They refuse to face up to a conflict. They'll either pretend nothing is wrong or just give in, but really something is wrong.
Okay. Do you know of someone in your life like that?
Yeah.
I think we all do, right? Same thing with the avoider. How about the guilt maker, Ange?
Guilt maker is like try to make their partners feel responsible for causing pain, something like that.
Okay.
Yeah.
Do you know someone in your life like that?
Sometimes me, of course.
Okay.
Yes.
The subject changer, Diane. Who's the subject changer?
The subject changer is an avoider who escapes facing up to aggression by shifting the conversation whenever it approaches an area of conflict. Because of their tactics, subject changers and their partners never have the chance to explore their problems and do something about them.
Very good. Know someone in your life or work?
Yes.
All right. How about the distractor, Jackie?
Rather than come out and express their feelings about dissatisfaction, they attack the other person's life, so they never really share what's on their mind because they don't want to talk about it.
And you know someone?
I do.
Okay. All right, let's go on to the mind reader, Brittany.
Instead of allowing their partners to express feelings honestly, mind readers go into character analysis, explaining what the other person really means or what is wrong with the other person. By behaving this way, mind readers refuse to handle their own feelings and leave no room for their partner to express themselves.
I think we can pretty much pick all of these out and find someone in our lives, whether it's a co-worker or family member or friend, who pretty much, fills in for any one of these, right? I'm not going to continue going on.
Can't you have a couple, Doreen? I mean, you can have a couple of these, really.
Yeah, absolutely. Who is the Christless tickler? Diane?
Christless tickler bring what is bothering them almost to the surface but never quite expresses their true feelings. For instance, instead of admitting concern about the finances, they innocently ask, geez, how much did that cost? Dropping a rather obvious hint but never really dealing with the crisis.
Yeah. Okay, how about the trivial tyrannizer, Liz?
Instead of honestly sharing their resentments, trivial tyrannizers do things they know will bother their partners, such as leaving dirty dishes in the sink, turning the television up too loud, burping.
Okay, how about the blamer, Jackie?
Blamers are never interested in finding faults within them and resolving a conflict. Needless to say, they usually do not blame themselves. Blaming behavior almost never resolves a conflict, but it is an almost surefire way to make partners defensive.
Okay, and how about the Benedict Arnold, Ange?
Benedict Arnolds get back at their partners by sabotage, by failing to defend them from attackers, and even by encouraging ridicule or disregard from outside their relationship.
Very good. So, moving on to barriers to communication. There's physical impairment. Let's look at critical thinking application 5-5. What must be considered when communicating verbally with Mrs. Cloyd? What do you think, Brittany?
I would say that her health, the health issues that she has, her age, her emotional status.
Yep, exactly. How about when we're communicating with Sarah? What do you think, Liz?
Take into account that it is her mother that we're talking about. Make sure you're not ignoring her mother, but make sure that she's also included.
Yes, all important things. Language, we want to make sure when there are non-speaking English patients that we might need to use gestures or more body language to convey certain messages. With prejudice, make sure that you don't have any personal or social bias or prejudice. This might bring about some discrimination, and this is usually unfair treatment. Stereotyping, you just want to be aware that you don't stereotype any of the patients that walk through. And then perception, which we've talked about before in the instance of, a patient's perception of the office, but also our perception of who we're treating. Make sure that we consider, don't look at them and think, oh no, they're not going to understand what I'm talking about because blah, blah, blah. That's not appropriate. Overcoming barriers to communication or communication during difficult times. Well, during anger, one of the most difficult times to communicate. Usually anger, expressing this is usually healthy. I know it doesn't seem like it, but it usually is. It's the unexpressed anger that usually causes or contributes to all types of health problems. The anger, you have to remember, is not usually directed toward the medical assistant. Just try to be a good listener. Use logic. Do not use absolutes such as never and always. And try to remain calm. When there's shock, there's many types of shock that might occur. And usually this happens after some type of a catastrophe. Your patients often can't think or move. They might scream in agony, and others seem almost normal. You never know how someone might react in deeply stressful situations, so you have to be aware of who's around you and what's happened, and usually their reactions might differ from time to time. So, critical thinking application. Is it possible that Sarah might experience shock months after her mother's death? What do you think, Diane?
I think that she can. She may still be going through the stages of death, so she could still go into, especially if she's not wanting to deal with it. At some point, she's going to have to.
Exactly. Okay. How can you, the medical assistant, help Sarah deal with these emotions? Jackie?
You can have some of assistants, maybe see a psychiatrist or a counselor or a priest, just somebody else that's gone through it that can help her start with the healing process.
Right. Have resources available to be able to communicate them to Sarah. Death and dying. We all have heard about Elizabeth Kubler-Ross. She studied thanatology, which is the study of the phenomena of death and psychological methods of coping with death. We're on page 73. We all know that there are 5 stages of grief: denial, anger, bargaining, depression, and acceptance. We all recognize that there are multicultural issues on page 74. So sometimes we think that people all over the world think and behave as we do. So what happens is we are often stereotyping those from other cultures and think that we understand them. But those that are from other geographic areas, even within the same United States, experience culture shock in new surroundings. So don't assume that someone from California who's just come out to Maine for the first time isn't going to have culture shock, or someone coming from Virginia up, or even us going out to Arizona or Texas or up to Michigan. There's a little culture shock. Everywhere is different. So you want to have patience. Patience is important. Communicating with those from other cultures, treat them as you wish to be treated. Try to overcome the language barrier. Be patient when you're communicating with them. Encourage patients to bring a translator if it's necessary. And try to understand some nonverbal communications of the other cultures as well. As I mentioned, with the non-English speaking patients, they might want to bring an interpreter. If they don't, attempt to find someone who can help to communicate. And where is it? In Lewiston, you actually have a large Somalian population. So a lot of times they need to bring interpreters with them to doctor's offices. You want to have a sensitivity to all the patients. So any patient who might have anxiety when seeing a physician, you have to be sensitive about the patient's feelings. Always explain the steps or procedures that are being done to put them at ease, and try to display a caring attitude. On page 75, we see Maslow's hierarchy of needs. We have physical needs, safety needs, social needs, self-esteem needs, and self-actualization. I'm not going to go through each one of those with you. You've read this part of the book. It gives you a good figure at the top there of a pyramid. For some human needs, we want approval, acceptance, and achievement. And we all need a good night's sleep. So there's stages of sleep. There's two main phases. We have the non-rapid eye movement and we have the rapid eye movement. What is the non-rapid eye movement? Jackie?
You're in a dead sleep. You're not, not doing anything. It's right where you are. I am.
Non-rapid eye movement.
Oh, you're not doing anything. You're just sleeping. You're not into a deep stage of sleep yet.
Okay. So then the rapid eye movement is where we're in a deep sleep, where the dream occurs, the brain is highly active, you see the eyes moving rapidly, and this usually occurs in the last hours of sleep. So, critical thinking application. Could Sarah's sleep and nutrition habits affect her ability to care for her mother? What do you think, Liz?
Yeah, I definitely think they could. If she's too stressed out and worried about her mother and not sleeping enough or eating right, then she's not going to be as much herself and be able to take care of her mother like she could.
Right. So how might these affect Sarah's personal stress levels, and how can she ensure that she is taking care of herself when her thoughts are primarily on her mother? What do you think, Brittany?
Well, if she's not eating right and not sleeping well, then it definitely could, she just takes an emotional toll on your body. She needs to definitely make time for herself, do things that she likes to do throughout the day, and try to focus on her mother, but also focus on herself.
Yeah, very good. So let's do a summary. So we have a lot of people who face death or other catastrophes, and they want to be treated just like everyone else. So make sure, greet them in a warm, friendly manner. Make sure that they know that you care about them. Be sure that patients understand their medications and their treatments. Direct them to community resources. Right? I know I mentioned this early on. Make sure you have a list of resources available. And listening is one of the most important skills that you can develop. Your interpersonal skills are going to be critical to you as a medical assistant. Communication is part of virtually every event during every single day that you have. You want to enhance your interpersonal skills and your relation skills at every opportunity through classes and continuing education. With all of the stuff that is out there on YouTube, there's all kinds of stuff that you can Google and listen to. And usually some of it's less than an hour long. So you can be sitting there listening to it while you're studying or trying to do some folding laundry and stuff like that. All communications must be effective to be of benefit. So sometimes a person has to hear it many, many times before they finally get it. And if you look at someone and you see that glazed look over their eyes, you can say, "Have I lost you? How do I need to say it so you can understand me? What are you missing here?" Okay? So critical thinking application. Often survivors feel a sense of unfinished business with a person who has died, and they have a more difficult time bringing closure to the relationship. How might Sarah spend high-quality time with her mother and come to terms with her death in a positive way? What do you think, Jackie?
For myself, I think that I would write a letter and say, you know, that you love her and that you're glad that you're your mom. For me, that would be something that I do because I'm very outspoken. So I would let my mom know before she passed away that I loved her, I appreciated everything that she did. At the same time, for me, it would probably heal my soul and my heart because I am able to say that and maybe make her at peace. So both people would be at peace. And at the same time, if the mother had something to say, that would maybe be a good time for her to say her piece at the same time.
Yeah, definitely make a time where you and your loved one have the ability to really say those types of things, not necessarily in a life-threatening event or where you know the person is dying. Sadly, that's when most of this happens. Brittany, I don't know how much you've experienced with that, but it can be pretty painful during the situation. And
Yeah, we deal with it a lot. It seems like on the dementia unit, it's kind of hard for family members to come in and witness their loved one not knowing who they are, not being able to talk, not being able to do daily tasks. So it seems like they come in when the resident is on their, their deathbed, and I mean that's just how certain people cope. So yeah, we definitely see it a lot.
yeah,
I
it is
think,
hard. It
Doreen,
definitely is.
I think that the older generation, they don't show their feelings as much as the younger people do. So that's hard too when my ex-husband, he never kissed his mom or never said I love you to his mother. It wasn't until we got married, I'm like, don't you tell your mother you love her? You know, it just seemed weird, but he was never raised that way because that's the way that she wanted it. So, but I think the older generation, no holding hands, no kissing, that's part of that type of generation. So it's harder for them to be open like that.
Right. It is. I agree. All right. Let's see here. right, let's move on to chapter 6. Does anyone want to take a quick break? Get up, move, stretch. Okay. Chapter 6, page 80. We're going to talk about medicine and ethics. All right, the opening scenario. Would you read that for me, Diane?
Monica Johnson has been employed for 6 months as a medical assistant in a family practice. She works as a clinical medical assistant for Dr. Richard Way. One of Dr. Way's patients, Anna Welch, recently adopted a baby after 8 years of trying to conceive a child. The baby, Delaney Gasolina, was born to a single mother, Susan, who participated in an open adoption in which she and the Walshes met and got to know each other during the pregnancy. Susan dated the baby's father for about 6 months before discovering that she was pregnant, and they are no longer dating. Susan wanted to make a good decision for her baby and decided to place her for adoption. Dr. Wade performed some genetic testing on Delaney, and the adoptive parents were involved throughout the pregnancy, even meeting Delaney's birth mother for physician appointments from time to time. Monica observed both Susan and the Welches and saw many benefits from the arrangements, noticing that everyone was primarily concerned with Delaney and her happiness and well-being. However, some periods were difficult for both sides. This prompted Monica to give some thought to her own feelings and ideas about many different ethical situations and issues and how she would react in the face of having to make ethical decisions.
And that's a hard part with medicine and ethics, because ethics concerns itself with the philosophies that underlie ideal relationships between human beings, as well as the promotion of the highest good for humanity. So when we as people make decisions that are based on ethical beliefs, it can possibly alter the course of, human existence or our human existence. So it's really a tough spot to be in. So what we're going to look at in this chapter will be the rights and duties that are related to ethics. There are 4 types of ethical problems: making some ethical decisions, the impact that CEJA has on ethical decisions made by healthcare professionals, and we'll talk about CEJA and what that stands for, and then the reasons that confidentiality is an ethical issue. And then the CEJA opinions, I'm not going to go through those with you. You can read them. We all have our own, and each person is able to have those. So let's talk about the history of ethics in medicine on page 81. So what ethics does is it explores the moral right or wrong of an issue, and it should not be confused with etiquette. Etiquette refers to courtesy, customs, and manners. So ethics is completely different from ethics. CEJA is the Council on Ethical and Judicial Affairs. Right. All right. On page 83, we have the Code of Hammurabi. What is the Code of Hammurabi, Liz?
It is a written code of ethical conduct for medical practice conceived approximately 2,250 BC.
Yes. And this is what sets the fees that a physician could charge. The Oath of Hippocrates, this was written in approximately 400 BC by Hippocrates. He was a Greek physician, and he is known as the father of medicine. This oath is administered to medical school graduates even today. Thomas Percival is an English physician and philosopher and writer. He also published his Code of Medical Ethics in 1803. The AMA was established in 1846. It formulated its first annual meeting in 1847. It specifically acknowledged Percival's Code of Ethics as its foundation, and it provides information and support to physicians. Now, the Council on Ethical and Judicial Affairs, over on page 84, it consists of 9 active members of the AMA. It includes 1 resident physician and 1 student member. It is also responsible for interpreting the AMA principles of medical ethics as it was adopted by the House of Delegates. All right. The components of the AMA Code of Ethics. There are 4 components. Principles of medical ethics, the fundamental elements of the patient-physician relationship, and the current opinions of CEJA with annotations, and the reports of the CEJA. Let's talk about the critical thinking application. Monica knows that she has deep-rooted thoughts and ideas about many ethical matters. However, she has never really thought about where she formed her ideas. Where do we get most of our opinions on ethical or moral issues? Liz, where do you feel you get yours from?
A lot of it is from how you were raised and what you grew up around, and the people around you, what you've learned is socially acceptable, as well as your own opinions in your head.
Okay. What about you, Brittany?
Where do I think that I got my where I got my morals?
Your opinions on ethical and moral issues, yeah?
I think that mine, I don't know, I think it stemmed from my parents, where I learned it from. Like my parents and what they taught me growing up, and my grandparents, what I've seen.
Good. Okay, how about you, Ange?
For sure, yeah, I get it from my parents too, and my great grandparents.
Okay.
Yeah, especially.
How about you, Diane?
I'd have to say my parents also, and the Catholic school that I went to.
Yeah, those nuns and those rulers. Yeah. No, I have to agree. We all get it from family, parents, grandparents, basically, who raised us, the schools that we went to. You know, if we had some teachers who were, you know, really influential in our education, different things like that. If we met people along the way who kind of took us under their wing and mentored us and, you know, guided us, those types of things. So good. Thank you for sharing that, everyone. All right. So publications, Code of Medical Ethics. The current opinions come with annotations. They contain the first 3 components, and then it contains the discussion of more than 100 and 35 ethical issues that are encountered in medicine. And then you can also read the reports of the Council on Ethical and Judicial Affairs that actually discuss the rationale of Council's opinions. So when we're making ethical decisions, we're still on page 84 in the right-hand column. First, we must understand the elements of ethics, and then the types of ethical problems, and then the decision-making process. So there are 3 general elements of ethics. First, it's the duties, the rights, and the character traits. So what are the duties, Jackie?
To always be respectful to the patient, try to assist them whenever you can, and try to, just do the best that you can for them.
Okay. Well, what do you think is a right, Diane?
Things that you have a right to in the Bill of Rights and what they told us. Although reading this, I've learned that medical is not a right, is a privilege.
Yes. Yes. Rights are defined as claims a person or group makes on society, a group, or an individual. And then we have character traits, which is a disposition to act in a certain way. So as a medical assistant, it is our disposition to act in a certain way. Remember, we represent the people that we work with and for. So some of the types of duties are non-maleficent, which means refraining from harming oneself or another. Beneficence, bringing about good. Fidelity, concept, promise keeping, and veracity, telling the truth. We also have justice, which is fair distribution of benefits and burdens among the individuals and the groups. Reparations, which is righting a wrong. And then gratitude, feeling grateful after being the beneficiary of someone's goodness. So let's talk about rights versus privileges. When we talk about rights versus privileges, the Bill of Rights guarantees that there are certain liberties that we may enjoy as a U.S. citizen. Americans do not have the right to health care services. It is a privilege. Rights apply to all people within a group without prejudice. So consider the phrase, the right to life. The right to life.
The right.
Character traits, they don't always indicate how a person will act in every situation. No human being is perfect, and humans are often unpredictable. Over on page 85, let's talk about the types of ethical problems. What would be considered an ethical distress, Brittany?
An ethical distress, I don't really know.
An ethical distress is a problem in which a certain course of action is indicated, but some type of hindrance or barrier prevents that action.
Is that?
All right. So I know which of course action should take for a patient's benefit, but there is a structural barrier to my being able to do it. So the agent, I know which of course what action I should take, but we don't know what's going to happen, what's going to be the outcome. All right, ethical dilemma. What is an ethical dilemma? Liz?
An ethical dilemma is where you have 2 or more choices and they are either both right or wrong. In one way, you're going to have to sacrifice something.
Okay. And dilemmas of justice. What is a dilemma of justice, Jackie?
There are benefits to be distributed among several potential beneficiaries. Not everyone can receive the full measurement of the benefit. On what basis should that be distributed or made?
Right. And locus of authority, Diane?
There are two or more agents or authorities in the same situation believes he or she knows what the outcome will benefit the patient the most, but only one authority will prevail.
Right. So it's not always easy to recognize the type of ethical problem that is present. So sometimes there's going to be a mixture of problems that exist. So the ethical decision-making process, what we need to do, there's 5-step method for making the decision. Gather the relevant information, identify the type of ethical problem, determine the ethical approach to use, explore the practical alternatives, and complete the action. Critical thinking application 6-2. What are the ramifications of an open adoption such as Delaney's? What do you think, Liz?
Well, it could be hard on the parents, or the adoptive parents, knowing the mother, Sarah, I think was her name, right?
Yep.
Yeah. It could be hard knowing her that, you know, they're gonna feel they're both gonna know each other's emotions and know each other going into it, so it could be difficult.
Yeah. And how might these problems be prevented, Brittany?
Prevented, I would say, to to think about it and talk about it beforehand, I guess.
Yep.
Being very open with each other about what could happen.
Yep. Okay, what are some of the positive aspects of the adoption? What do you think, Ange?
I have no idea. Positive aspect, adoption. Sorry.
Okay, what do you think are some of the positive aspects of the adoption, Jackie?
I think that the child might have a better life. The mother could probably, hopefully, get her life together and, you know, be able to see the child. Sometimes the families let the mother see them. Sometimes they don't. It all depends, like Liz said, get an open, open like contract or what you want from this. Are you
Right.
are you going to let him in there or aren't you not?
Right. Okay, let's move on to some of the current opinions of the council, and we'll just pick out a couple of these. Allocation of health resources. What is the current opinion of the council on allocation of health resources? Diane?
Sometimes the society must decide who receives care when serving all who need care is not possible. Decisions must be made fairly and should be weighed carefully. The criteria to consider when allocating health resources include urgency of need, likelihood of benefit, duration of benefit, amount of resources required for successful treatment, and potential for change in the quality of life. Non-medical
Stop right there.
Okay.
So if we had the CEO of American Airlines, the winner of last year's Best Oscar, and a drug-abusing mother of 3 were all equally ill and needed a liver transplant, who do you think should receive it? Based on what the council says.
I would say the one that would have a better chance of the liver being kept inside. I know that some people have not a good chance of it taking, where some other people do. So maybe that might be an option there.
Yep. They're going to look at all of the criteria, but what should not be considered is the ability to pay, the social worth, the age, the obstacles to treatment, and the patient's contribution to the illness. The physician has to remain the patient's advocate and should not be involved in making the allocation decision for that patient. So there are procedures put in place to determine who would be the best one to get that. Okay? Stem cell research. What is the council's position on stem cell research, Liz?
It's an area of disagreement because some think that if you're working with stem cells, that's the basis of human life. But other people want to use it for research for good for Alzheimer's and Parkinson's and things like that.
So we have a medical student who is recruited to work with a physician who is researching paralysis. Once the project is underway, the student discovers that the physician is using embryos that have been questionably obtained. What should the student do? What do you think, Jackie?
Jeez, that's you should report it, because that's not fair to the cells that are being taken away from somebody else. I think that when the child's born, don't they ask you if they want like the umbilical cord, the umbilical cord
I
and the
believe
things
so.
that go with it, and if that's being taken, then that's the parent's rights to that, stuff, and the doctor should be taking something that's not his.
Right. All right, critical thinking application. How might the genetic testing done in Delaney's case have caused an ethical dilemma? What do you think, Brittany? Sorry.
Sorry, I'm eating. How might the genetic testing done in Delaney's case have caused? I don't know. I'm still like a little bit confused on the ethical dilemmas.
Okay.
So I don't really know, to be honest.
That's all right. What do you think, Diane?
Well, when they did the testing, had it come back that she had that the baby had Down syndrome or some other problem, the adoptive parents may have changed their mind and not wanted her.
Correct. Exactly. So any genetic testing could have caused an issue with the adoption, right?
Right.
Okay. How about over on page 88, quality of life. All right, quality of life. A mentally ill single woman who is institutionalized becomes pregnant and refuses to give up her maternal rights so that her child can be adopted. Even if she were to reconsider, what complications would result if the child were born deaf and with a severe liver disorder? Should the child be fed and cared for by the hospital staff? What do you think, Liz?
Yes, I believe so. I mean, it says here that the physician's primary consideration must be what is best for the patient, but once the patient's child is born, that makes them a patient as well.
Right. Yep, excellent. All right, critical thinking application. Monica has often thought about being an organ donor. She is very much in favor of organ donation because of her interest in the medical field. Her parents are very opposed to this because of their religious beliefs. How can Monica deal with this conflict within her family? What do you think, Ange?
I think Monica should talk with their family with her family about it, and let them understand that he likes to, donate her organ, to be an organ donor, something like that. You
Okay,
have to let understand something,
very good.
I think.
Okay. Let's see. All right, some other ethical issues that might come up would be interprofessional relationships. A medical assistant or medical professional should speak up when errors by other professionals are suspected. Referrals to other professionals should be made only when one is confident in his or her ability. Turn the page to 90. In the physician's private practice, they are free to decide whom they will treat. Confidentiality and patient privacy. It is unethical and unacceptable to divulge any information about a patient to any person not directly involved in that patient's care. We have talked about this before, and we will continue talking about it throughout these chapters. All information in the record must be kept in strict confidence. So, critical thinking application. Susan, Delaney's birth mother, comes to the office for a checkup 6 weeks after the baby was born. She looks a little sad, and when Monica questions her, she asks how Delaney is doing. What should Monica tell her? Jackie?
I just turned my fucking period. She should tell her
serious?
whatever's on her mind.
Yeah, I just got
If
over
she has
it. I don't
concerns
know.
about the baby, she should say something. If it's learning to adjust to having a child, say something to them. So that way, at least they'll know what's wrong, and she'll be able to get the help that she needs.
Okay, but she has to be careful in regards to HIPAA, because Susan is asking, asking.
Yeah, she asked her what's wrong.
Right.
I'm just using that as a couple of examples. You know, maybe the child's not feeling good. Maybe she has concerns about the child from the test or something.
Okay. What do you think, Brittany?
So Monica is the medical assistant, right?
Right.
Okay. I would say that unfortunately, we can't really talk about it right now in the office. Maybe we could set up a time to talk on the phone or something outside of work. Maybe that's
Do you
what I
think
would
there's any violation of confidentiality here?
I don't really know.
Yeah, I think there is. If she doesn't have permission to give out that information to her, she'd have to have permission of the adoptive parents before she could say anything.
Even though it's an open adoption, they still have to abide by confidentiality. Because she's the birth mother does not mean she has a right to the information.
Is Monica not the adopted mother?
Monica is the medical assistant.
Oh, okay. I got them confused.
That's okay. Okay, so some other ethical issues that you might run into would be advertising. You don't want to have any deceptive advertising. You know, don't bring your patients in for a free exam. Communications with the media. Medical professionals cannot discuss any patient information with any member of the media without his or her written permission. Well, you as a medical assistant would not be doing that, I hope. Physician obligations and emergency preparedness and response. Your physicians are ethically obligated to provide emergency care during disasters. Some of those might be hurricane, epidemics, terrorist attacks, malevolent use of biomedical research. This is where a physician must assess the possible ramifications of participation in research before engaging in projects. Racial and ethnic healthcare disparities. Patients are entitled to the same quality of care regardless of their race or ethnic background. Diagnostic imaging on request. Physicians should perform the diagnostic imaging only when they believe that it benefits outweigh the risks that are involved. Computers only authorized personnel, I should say all authorized personnel must comply with HIPAA regulations with regard to the computer use. Charging or collecting an illegal or excessive fee is prohibited. Fee splitting and contingent fees, those should not be done. Insurance forms over on page 92. Your facilities are allowed to charge for completing medical insurance forms. No, not usually. If they're charging for them, it's not correct. It's not ethical. Waiver of insurance co-payments. The routine waiver of insurance co-payments might actually violate the contracts with your insurance company or your managed care organization, so be very careful that you don't do that. Professional courtesy is another area that is, physicians may offer professional courtesy discounts, but it has become less common in the recent years. Your office policy manual should provide strict details and guidelines about the issue surrounding professional courtesy. Appointment charges. It is completely ethical to charge a reasonable fee for missed appointments that are not canceled or rescheduled in accordance with the office policy manual. Your patients must be informed of that policy regarding missed appointments. Prescribing drugs and devices. Your physicians should not be influenced by prescribing drugs or giving out devices or any appliances that show might receive some type of financial interest from the supplier. Professional and contractual relationships. Your physician should negotiate the wording of contracts that shows there is no question of financial incentives for the physician that would in any way compromise the professional judgment or integrity. Healthcare facility ownership by a physician. Your physicians might actually own the health facility or they might have a financial interest in it. So there must be a disclosure to this connection to the patients before they're even referred to the facility. That can actually be considered a kickback. A ghost surgery. This is an unethical way to substitute surgeons without patient knowledge and consent. The patient should always be consenting to the surgery, knowing who is doing it. Discipline within medicine is where physicians should expose incompetent, corrupt, dishonest, or unethical conduct by members of the profession. If there is substance abuse, you should be telling someone about it. Unethical conduct over on page 93. Be absolutely sure you have all of the information. Decide whether or not the information should be reported and to whom it should be reported. Determine if working for the professional who engages in this type of behavior is best interest for you. So to summarize the scenario that we had at the beginning and went through, There are always two sides to each situation. Be non-judgmental toward patients and coworkers. You never want to inflict your personal opinion onto patients. And periodically perform a self-evaluation regarding your ethical views. Make sure you stay on top of current issues that might have some ethical implications. So, for you, Brittany, working on the dementia ward, it might be to your benefit to stay on top of any issues that come about based on, patient care around dementia, any type of, family assistance, whatever's going on within the facility. Determine what your personal views are on each of the opinions that we discussed here in the text. Your belief systems are yours. They're personally created and they can change. Just because what you believed it today, or you might have found other information that really changes that belief. That is your own personal choice, your free will. And that takes us through chapter 6. All right. Any questions, ladies? Any questions?
I do. Go ahead.
Say it. Go for it.
Well, I'll go. On the sheets that we have that you put the grades for, Doreen,
Yes.
it says that sim chart exams. What are we taking those, or is that what that little book was for?
That is the electronic health records, and we won't be doing the sim chart until the end.
Okay,
So
I didn't know because I was just wondering about that.
Yeah,
okay.
You don't even have to worry about sim chart until the end.
Okay.
All right, next question. Okay, so we did 5 and 6 tonight. For next week, we're going to do 7 and 8. What I would like you to do is do the practice stuff on Evolve for now. And let me write this down so I don't forget it. You should all be getting your study guides within the next week. As I said, we're not so far into the course that there's a lot for you to get caught up on. What I say, get caught up on. When you do get your books, really what I want you to do is a lot of the vocabulary and matching and, the true and falses, filling stuff out. The case studies I'm not too worried about, but your study guide is going to be more practice, and that's really what I want you to focus on when you get the books. But go ahead and when you get your books, let me know that you've gotten your study guides. So for next week, read chapter 7 and 8, review the critical thinking applications, think about how you would do some of those things, because the critical thinking really is what we go over in class as well. Do all of the practice and play stuff on Evolve, quizzes, the rubrics, medical terminology, the practice stuff, whatever you can, fit into your schedule, that would be great. Anything else, ladies? No? So, Jackie, if you do set up Jabber, let me know so that I can let Mount Ararat know. That's why the system wasn't on probably when you got there, because I didn't know you were going there.
No, Amy was here last night for our medical terminology, and we talked about that. So I texted her last night to let her know that I wasn't able to connect it and stuff after I let you know. So I'm going to try to work on it again with the other computer and see if I can hook it up. If I can, I'm going to let her know too, and I'm going to let you know as well. But she knew last night that I was going to try to make it work.
Okay, well, that didn't get passed on to me, so I didn't set up the system to call Mount Ararat.
The lady that was here, she was actually from the academy, and she was setting it up. She actually left a paper on the table to how to actually set everything up in case something happens. So she was already here. She knew that from Amy. And I sent your email to the dd@maine.rr.com. That's where I sent.
AD,
ADD.
Apple David, David, Mary.
Yeah, I couldn't remember the whole thing, but I sent you one last night to let you know that I wasn't able to do it because of the.
I didn't get it.
Okay. Well, I did send it, but.
Okay. Very good. Okay. Any other questions, ladies?
Yeah, I tried the 4 quizzes from chapter 1 to 4, and then I just wanted to. I'm looking for my score for that, and I couldn't find it. Is it? I don't know.
Okay. You have to remember that quizzes are different from exams. So if you did a quiz, it's just practice. The exams are going to be under chapter exams. Let me look at my Evolve again just to make sure. If you go under Ken's Medical Administrative Assistant and you go over to chapter exams on the left underneath Content Home, you will see under chapter exam heading that you have all of your chapter exams. Now, you're going to have to scroll all the way to the bottom to start with 1, 2, 3, and 4. Your chapter quizzes are just that. They are found underneath their chapters, underneath your resources. So I don't care about your chapter quiz exam score. If you don't get it, I'm not sure how to get it for you. But I don't know that it really matters because it tells you if you got it correct or if it got wrong. I think it gives you, like 3 tries to get the right answer.
Okay.
Okay. Just, I'm more concerned with the exam score. Okay. How about you, Diane?
I guess my only question would be, I sent you an email last week to look at the quiz, the chapter exam 2 with like 5 or 6 numbers I wanted you to look at, and you told me you would do it over the weekend, but I don't believe that you have.
Probably not. Chapter 2.
Correct. Correct.
And could you look at my chapter 1 too? Because a lot of my answers were right, but I instead of pros and cons, I wrote pro and con, so it marked it wrong.
Okay. All right. Anyone else? Okay. I'll do that when we get off the lecture here. So until you get study guides, which will be in the next week, we'll go over answers in class, the first part of the class, once you get your study guides and you get some of the work done. So for now, we'll call it a night, and we will see you back here next week.
Thank you.
Have a great week, everyone. Thank you.
You too.
All right. Bye.